passcode untuk masuk gitu adik-adik. Nih ya, adik-adik coba perhatikan, semoga tidak ada kendala. Sebentar. Putus-putus ya adik-adik ya. Tidak bisa. Kenapa ya? Oh no, saya padahal pengen nunjukin ini ke adik-adik. Waduh, kok jadi macet? Kayaknya nggak mau mbok tonton ini loh adik-adik, jadi macet tuh. Padahal kemarin-kemarin nggak apa-apa. Bentar ya. Saya juga bingung kalau begini. Mana ya? Bentar ya adik-adik, kok nggak mau ya? Sebentar, mau kayaknya.
Tracheal intubation is the most effective routine method for gaining control of a patient's upper airway. Intubation is used most often to maintain general anesthesia with a gas anesthetic, but it's also essential during management of respiratory emergencies and for positive pressure ventilation. Intubation may not be possible in cases of upper airway obstruction by a foreign body or a mass, of mandibular or maxillary fractures, or in cases of tracheal surgery. Extension of the neck must be avoided if it risks worsening cervical spinal cord or vertebral disease. Intubation is only appropriate in patients that are unconscious, with gag and swallowing reflexes diminished or eliminated. Generally, anesthesia is induced immediately before intubation. An endotracheal tube of appropriate length, a roll of gauze, a laryngoscope with adult or pediatric blade, and a syringe to inflate the cuff are necessary. Typical endotracheal tube diameters are listed here. Sterile water-soluble lubricant, local anesthetic spray, and a mouth gag are used by some clinicians and not others. Pre-measure the length of the tube, which typically should reach from the tip of the nose to just caudal to the point of the shoulder. If it's too long, remove the connector piece and trim it from that end, not the cuff end. The patient must be sufficiently anesthetized or obtunded so that airway reflexes and conscious movement of the head and neck are inhibited. Sternal recumbency makes the procedure easiest, but lateral or dorsal are acceptable. Anticholinergics are administered by some clinicians with the goal of reducing the volume of airway secretions. It can be helpful to review landmarks prior to the procedure. The obstacles to be cleared on the way to the glottis will be the teeth, the tongue, the soft palate, and the epiglottis. This computed tomography sequence shows these structures in grayscale and the endotracheal tube in green. Note the position of the tube rostrally, between the incisors, because they are less likely to cut the tube than are premolars or molars if the animal regains consciousness while intubated. The tongue is deflected laterally to improve visualization of the airway, and the soft palate is pushed dorsally by the tube and the epiglottis ventrally to reveal the opening of the glottis for intubation. After inducing anesthesia, typically by IV injection like this, have an assistant open the patient's mouth. The assistant's fingers or length of gauze go caudal to the maxillary canine teeth, which also lifts the lips out of your way. The assistant should elevate the patient's head and extend the neck so they form as straight a line as possible. The assistant holds the mandible and tongue in his or her other hand, so you can hold the endotracheal tube in your dominant hand and laryngoscope in the other. The goal is to pass the tube smoothly into the trachea, like this. Let's look at it from your perspective. With the assistant holding the patient's mouth open, you see the soft palate, which you sometimes need to elevate off the epiglottis to reveal the opening of the glottis, like we see here. The glottis is the gateway to the trachea, and it is our target, this vertical black slit. Advance the tube into the glottis, which can be helped by rotating it so the beveled edge enters the glottis vertically. Gentle back and forth twisting motions may be necessary, but the tube should pass between the vocal folds and into the trachea without force. Here's another look, fuzzier but even more on target, using an endoscope. This Yorkshire Terrier has the mouth held open and a laryngoscope is in place. We're now following the exact path that the endotracheal tube will follow. Into the mouth, then at the larynx, and when the glottis is open, we advance and we're in the trachea. With the tube in the trachea, connect it to the rest of the anesthetic circuit and set the initial oxygen flow and anesthetic concentration as needed. Fasten the tube around the maxilla in dolichocephalic and mesaticephalic dogs, as we see here, or caudal to the ears in cats and brachycephalic dogs. Inflate the cuff to a pressure that creates a seal, which you can check by having the assistant close the pop-off valve and give positive pressure ventilations for a few seconds, while you listen for air leakage and adjust the pressure of the cuff as needed. Remember to open the pop-off valve immediately afterwards. It's important to be sure the tube is correctly in the trachea and not in the esophagus. Ways of doing this include the following. Observe the rebreather bag for filling and emptying that clearly match expirations and inspirations respectively. Observe the endotracheal tube and rebreathing circuit for vapor on their walls during expiration. This is an advantage of transparent tubes compared to opaque ones. Close the pop-off valve, administer 2 or 3 breaths, and note that the pressure rises to 20 millimeters of mercury, and then reopen the pop-off valve. If any doubts persist about the tube's location, then re-examine the larynx with a laryngoscope to confirm correct placement. Pearls. You can spray topical lidocaine onto the cranial surface of the larynx immediately after anesthetic induction and before the first intubation attempt. This can reduce laryngospasm, especially in cats. Some clinicians use a soft stylet, like a polypropylene catheter, placed inside the endotracheal tube and that extends out the distal end of the tube. This way the stylet enters the glottis and trachea first, and the endotracheal tube simply feeds over it. This is especially useful in cats that are prone to laryngospasm. Avoid overzealous insertion of a tube that's too long. The tube could pass into a bronchus, leaving the other lung uninflated and risking hypoxemia. Thank you for watching this clinical skills video in veterinary medicine.
Baik, adik-adik mungkin itu sedikit gambaran orientasi terakhir itu yang mana dan lain sebagainya. Nanti adik-adik bisa melihat mungkin gambar yang tadi sedikit lebih jelas dibandingkan mungkin kalau adik-adik melihat di YouTube dan lain sebagainya. Baik, sebelum ditutup karena sudah jam 12, masih ada pertanyaan dari adik-adik? Dijawab dulu, kasih tandanya iya atau tidak. Halo?
Mungkin sudah cukup, Prof.
Baik, ya, baik. Mungkin kalau sudah cukup, saya izin menutup pertemuan siang hari ini, adik-adik. Mohon untuk yang menyajikan segera mengirimkan PPT dan makalah yang tadi dipresentasikan ya, supaya saya bisa segera memberikan penilaian untuk saya kirimkan ke IJMK, sehingga adik-adik tinggal fokus untuk menyambut UTS saja. Baik, adik-adik, terima kasih banyak. Sampai ketemu nanti setelah UTS. Selamat siang. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih, Prof.
Terima kasih, Prof.